Now, it is my pleasure and honor to present Professor Quirke, Head of Department of Pathology and Tumor and leader of the Leeds Institute of Cancer and Pathology. And she spoke about novel histopathological, predictive and prognostic factors, digital pathology. Professor Quirke.
Thank you very much. I can thank Professor Zinos and colleagues for yet another wonderful trip to Crete, enjoying the sunshine as well as the company, having a very nice time as per usual. It's very nice for us to be able to show off our technology. So I've spent years watching laparoscopic surgery and robotic surgery, so we pathologists are not as boring as you think, and we have some fun technology, and I will show off some of the things we can do with it now. And I've been asked to talk about digital pathology. So, microscopes have evolved from the first microscope that you can see on your left through to technologically more complex instruments, but they're all still the same. They have a lot of issues which I've listed down there, which are limiting, and can we actually move on from that? The technology has changed with the introduction, of course, of computers, online textbooks, and so for many years we've been using microscopes as well as computers, but actually you can fuse the two processes to integrate both the analysis of tissues as well as bring the greater benefits of technology into our daily practice. So in Leeds we've been in this game since the early 2000s, and we now have a significant amount of technology, and that's interesting. Oh, there we are. Right, so these are the scanners we have in Leeds now. We've got about £1 million worth of scanners up on the top corner up here. This is the latest digital workstation that's been developed by Darren Trainer, one of my colleagues in the department. We have developed the software onto large high-resolution 4K screens, which are touch sensitive, you can move them around, and also on very high-resolution digital radiology screens here. And this is about the size of me, and you can see a nice image of bowel cancer. So it actually helps us not only with digitising the images, but also presenting them and interpreting them, and making them as efficient, but not more efficient than standard microscopy. And so it has the advantages of microscopy, that it's a permanent record, always available, viewed anywhere, anytime. And you can see here on the train to London, and you can see here some of the places in the world where I've accessed our digital pathology from across all 6 continents. It was difficult to get an internet access in Antarctica, so I didn't succeed there. We can integrate it with other digital data, and that's really very important, and we can digitally manipulate it. So it's an enabling technology for certain things. So we can use it for routine digitisation of slides, and also digitisation of tissue microarrays, which enable us to look at 200 cancers on a single slide. We can restain and manipulate images. So here are images which were taken from multiple different slides, and then they've all been restained to be exactly the same, which can be helpful in terms of improving interpretation between centres and even between your own H&Es. And then we can use it for second opinions internationally. We can use it for remote frozen sections and remote routine pathology, or all routine pathology, but that has huge costs. But I'm here to talk about what we're doing with colorectal cancer, and we've used it substantially for storage of slides and the publication of the pathology from clinical trials, so people can see what we're actually dealing with. And we've integrated that with radiology and other things. We do accurate, simple measurements, three-dimensional pathology, and then quantitation and automated algorithms here, which will go into some of these. And ultimately, it might be about artificial intelligence, but we won't talk too much about that today. You can look on our website, and it's up there. Please do visit, and you will be alongside 121,000 other people last year. and we have a number of things, but the important area to look at really is the clinical trials and the slides, and you can see what Darren and other people are up to in terms of the research. And we have a very international audience coming to visit. All of this, of course, takes a lot of storage, and we have 150 terabytes of data sitting there at the moment. Now, the clinical trials are the most important area, and we have clinical trials in colorectal, small bowel, and also in upper GI. And here are some of the clinical trials that we're currently involved in. And you can go in and you can look at the histology and see what you think. We have the trial protocols on there, and then you go in, you can look at the individual cases. And in some, it's only a single slide of normal and cancer, but in the later ones, it's absolutely all the slides that were actually available in that trial. Now, thanks to Rob Glyn Jones and the funding that we got there, and from a company, Sanofi, and basically Gina, we were able to integrate MRIs before and afterwards, with the macroscopic cross-sections of each of the cases, so you can see how well the surgery was done. This was in colorectal cancer, and then the individual slides themselves. And you can go in and you can do cross-sections. So here is the macroscopic, here is the microscopic, and then you can go in and look at small amounts of microscopic features. So we can actually integrate multiple modalities here to enrich the trial. So what have we been doing? Well, we've been letting international people access and do joint studies, and then we've looked at a number of things utilising the trials and utilising different algorithms and different mechanisms. So just to run through some of the things we've done, so Quasar is a randomised trial of no treatment versus treatment in mainly stage 2 with a few stage 3 cases. It's a very important trial because it's one of the only trials with a no treatment arm, and therefore you can separate prognosis and prediction effectively. And it's also a very large trial, and we have over 2,000 cases actually scanned on the instrument. And when Gordon Hutchins looked at the deficient mismatch repair staining on tissue microarrays, which were digitised, and he decided whether they were deficient mismatch repair or not on the basis of that. You can see that we got the normal distribution of right-sidedness here, with very few on the left side. And when we look in the Quasar data, which was analysed by Richard Gray in Oxford, who's a statistician for that trial, we could demonstrate there's a 42% lower risk in stage 2 of recurrences of deficient mismatch repair tumours. We also, because of the randomisation between no treatment and treatment, could look at the effect of deficient mismatch repair on treatment. Now in Quasar we get a very different answer to Dan Sargent, where he pulled 4 heterogeneous trials and said there was no benefit of giving chemotherapy to these people. We could see the same effect whether you had deficient mismatch repair or not. It's just that the deficient mismatch repairs had a lower recurrence rate, but still, if they recurred, well, you had a benefit of treating them. So we don't hold with the story at the moment that deficient mismatch repair cancers are less chemosensitive, essentially to 5FU, which was the only one that was being tested within this series. And just as a point to make, routine deficient mismatch repair testing is a worthwhile thing to do, not only because of the effects on prognosis, the potential for PD-1, PD-L1 inhibition if you are a stage 4 cancer, but also the benefits of picking up Lynch patients. So if it's possible to do, please try and do it, because it's a worthwhile clinical test, and even NICE approves it, which is pretty tough to get in the UK. Having colleagues come in internationally to review our series, so Iris Nagagal came in and looked at the classic series, and we put that alongside Wayno's slide review here and Iris's slide review of another series here, and did a tumour deposit study, which was really important because it suggests that tumour deposits are important, matching TNM8, which is good. It shows that tumour deposit cases have a higher risk of peritoneal metastases, which is very interesting, but also that if you had nodal deposits and tumour deposits, it was actually a much worse prognosis. So we would suggest that in TNM9, moving forward, that actually if you find both tumour deposits and nodal deposits, that actually they should be in a higher risk group than they currently would be stratified. So just routine histopathology, it can be done internationally by other people looking at our slides and then moving on to us doing the analyses on the outcomes. But we can look at other factors. So this is some work by Gordon Hutchins, again in Leeds, on quasar, where he's testing the hypothesis of low stromal tumours do much better than high stromal tumours. And this has been suggested in a couple of randomised trials, so we tried it out in quasar, and he took the whole area of the tumour and then laid over the electronically scanned slides points which were digitally manually counted here as to whether they were tumour cells or stroma, and then looked at the outcome. And there was a test series and a validation series. Test series of 400 showed that yes, if you had higher stroma, you had a higher recurrence rate than if you had low stroma, which is what we were expecting from the a priori hypothesis. And then when you run it in the validation set of the other 1800 from the same series, you again see that stroma stratifies. And that multivariate hazard ratio is 1.62, which is the same as Oncotype DX. That's not surprising. Oncotype DX has stroma genes as one of its components, but it's a lot cheaper than Oncotype DX. We've also done it, or Scarlett Brockmuller has done it, in PT1s, and if you have high stroma in PT1 cancers, you also have a higher hazard ratio of having lymph node metastases. Now, budding has been around for many years, but we've had problems because of multiple methods. Some of the methods were using different size rings, others were looking at 10 fields. We've now agreed an international definition across the Japanese, the Europeans, the Americans, and we have a methodology whereby you look at all the slides, you find the slide with the worst budding, you then look at 10 areas on that slide, and you find the worst area, and then the worst area is quantitated using a specific size of field. And we've looked at it in stage 2, using digitized slides, quantitation of the area, and yes, we can confirm again that budding is prognostic, and it's got a hazard ratio down here of 1.71, so very similar to that of stroma, but they're independent of each other, which again is interesting. Also going on, Scarlett Brockmuller has done budding studies in PT1 cancers, and they're also prognostic. So we can confirm in a large randomised trial that budding using the new international method is actually a prognostic feature and is also in PT1. Now, the new kid on the block is immune scores. Everybody's very excited. Gallon got his publication in Science over it, and saying that quantitating the lymphocytes, specific types of lymphocytes identify different types of cancers. And he comes up with very, very impressive curves, and he says that this is actually better than TNM staging. Well, all I can say is that we have recently done this in quasar, and it's not published, but basically we cannot confirm, utilising our data, that data. And there are several other ones around at the moment, unpublished, which are not reproducing immunoscore to the same extent as was originally suggested. And it's always the way that people come up with their wonderful marker, and then when you try validation in different populations and different series, it doesn't validate as well as it does. So we can't say whether this is going to be valuable. I personally think that lymphocytes are important and it will be valuable, but where it actually sits at the moment is not up there where it's been suggested to sit, but it's somewhere in the middle, and we need to find out how we integrate these sorts of measurements in the most effective way into our routine practice. Now, we can go further with digital pathology. We can do three-dimensional pathology, and I don't have much time, but this is a three-dimensional model of the normal mucosa, and the yellow are the lymphatics, the red is the vasculature, the blue is the muscularis mucosae, and what this shows is that there is a very strong yellow line just underneath the muscularis mucosae, and that's in SM1. In SM2 you then have the vasculature, and then you have these major pathways coming through where the vessels go in and out. But within the muscle itself there isn't much vasculature or lymphatic drainage. Now, we, with Catherine Smith locally, have looked at and quantitated the distribution of the lymphatics, and most of them are actually in SM1, and less of them in SM2 and SM3. And so it made us think about actually how do we look at the risk factors in tumours for spread to lymph nodes in early stage. And we looked at a number of factors, but one included the area of submucosal invasion, another is a classic Japanese factor, which is the width of the cancer. And we looked at these and a range of other factors in 207 PT1s with a 9.1% lymph node metastasis rate. And what we could find was that actually, yes, the area of submucosal invasion appeared to predict better than SM1, SM2, SM3, or depth, and the width of invasion was also another factor which was of importance, as well as the standards for poor differentiation, lymphatic and vascular invasion, and that's just the area under the curve. So again, suggesting that simple quantitation might be an improvement. And Scarlett Brockmoller's gone on and done further work here, and looking at quantitative markers versus qualitative markers, the area of submucosal invasion, the width of the invasive cancer, as well as tumour budding and the relative proportion of stroma were all independent predictors, and that data is not shown here. But also poor grade differentiation, vascular invasion, and lymphatic invasion were also important. Now, what you should be doing here is a trade-off between what the patient thinks. Does he really want or she want a major excision versus the risk of those lymph node metastases? And this is a trade-off where we have to actually determine the risk for the patient. All I know at the moment is that there are too many people having major resections. The Japanese are resecting about 90% of them. We're resecting just under 50% of them. And what we need to do is to work out what the risks are, both for us missing the cancer and the need for resection. And what we can say is that some of these factors here are very specific but not sensitive, and these are less specific. So if you're using area of submucosal invasion here, just in this series, it's got to be matched and validated with other series. What we're doing is that one factor would reduce our resections down to 50%. If you were using just poor graded differentiation, then actually it would suggest you only need 4.3%. So what we're going to have to do is to look at all of these in multiple series and build an algorithm that gives you a relative risk of recurrence, which you can then discuss with your patients. Now, this 3D work has been really eye-opening to us because it asks the question, can we actually extend local excisions into PT2? And if we do, who should they be? And we think it's possible to do so. And we think we ought to be looking at this, and we are at the moment investigating PT2s on the basis and the hypothesis that actually if you have a wide cancer in SM1, that actually can be quite dangerous, and probably can be more dangerous than a rose thorn invasion, which is very narrow down into SM3, if the most important thing is the presence of lymphatics just underneath the muscularis mucosae, because this will be invading into potentially a large area of lymphatics, whereas this one will be going through very briefly and will have less access to your lymphatics. Now, if you have a very deeply invasive but very narrow SM2, I would put to you that might have a lower risk of lymph node metastases than a very widely invasive SM1. Why would I say that? Well, it's because here is the muscularis propria, here and here. And if you have a tumour coming in here, then potentially there's very few lymphatics once it gets into the muscularis propria. Once it goes into, if it goes into a vascular area, then that's probably very bad news. And so microanatomy and microscanning might be very important in giving us a truly defined risk for PT2 in the future. Now, three-dimensional pathology can give us other things. This is an H&E, and this is 3D reconstructions of the spread of these actual cancer cells, showing lumps and links, lump and links. And this may tell us something about the pattern of invasion, so we're going to do more work on actual tumour expansion using 3D pathology. And with Leiden, with Annelot Kramer and Nick on our GIFT anal sphincters, we've been doing 3D reconstruction and annotation of anal sphincters. Why should we want to do that? Well, we want to do that because we don't think we understand the patterns of tumour spread in this situation. we don't also understand the variation between one human and another, especially if they're male, female, old and young, and we feel that anal sphincters are extremely variable. And so what we have here is the yellow is the external striated muscle, the internal sphincter longitudinal is purple, and then the internal sphincter circular muscle is green. And you can see that we can demonstrate here internal sphincter longitudinal muscle actually coming through and lying in submucosa, and there's a variation in the amount of striated muscle and its relationship. You can see here that longitudinal muscle is breaking up quite badly, whereas here it's not. Understanding these variations, we think, will help us to understand the actual spread of tumour and more about this important structure, which has too little investigation. And then if we move on, finally, just to predictive, there are many predictors sought, lots and lots and lots of claims, but few ever validate. We don't know the value and importance of immune populations in who responds to chemotherapy, but it is very important in who responds to immunotherapy, and that needs a lot more work. We can look at the ligands for anti-EGFR therapies, and here is a low amphiregulin expressing tumour up here, and here is a very high expressing amphiregulin tumour, and also you see high epiregulin. Will these make a difference, and will these enable us to look specifically at who will respond rather than non-specifically by just finding an activated RAS mutation downstream of the receptor? We don't know. We think quantitation is going to be helpful about how much expression that you have and might help us to delineate things. We wonder whether artificial intelligence will succeed where we've failed over identifying these predictors, and with Foxtrot, which we have totally digitized with the digitized chemoradiotherapy series in rectal cancer, we think that we can actually provide the materials for those sorts of approaches going forward. So, in summary, we have our nice enabling technologies as much as anybody else does, and these are fun and interesting things to do. We think it's valuable for a wide range of investigations, from simple measurements all the way through to artificial intelligence. 3D pathology opens up new insights into biology, but ultimately the question is this going to replace us? And Nick and I will no longer be needed, and we'll no longer get very nice trips to Crete, for which we'll apologise. We'll have to come across on our package holiday instead. And of course, large numbers of people do all the work, and they're all listed here from the various studies. So thank you very much.
Many thanks for your excellent talk. Any questions?
I've got one up here, which is, should we include stroma and tumour burden quantitative measurements and histopathology reports? So we're getting there, but we're not there yet. I think stroma is definitely a prognosticator. We know from the simple studies of just looking at the tumours in the, firstly the Dutch, and then in the Victor study, and we've confirmed that in Quasar. So we have multiple randomised trials all showing the same thing. We also know that stroma was part of Oncocyte DX and is probably one of the main contributors to driving its prognostic value. And we also know that stroma relates to CMS4 subtype on RNA studies, and it's a lot cheaper to look at a tumour for stroma than it is to do RNA studies on every tumour. What I would say though is we don't know where it actually sits against all the other factors, and this is always the problem that we have, is that it's all very well having a new factor. Which one should we stop using in order to use this one, and what is the advantage? So what we need are gold standard studies where you have what we use at the moment, and then you include in the experimental arm what's the value of the new marker. Because if you don't, all that happens is you treat more people. And as Nikos said earlier, we don't really want to be treating more people. We actually want to be treating less people as the survivals get better in the adjuvant setting, and therefore we have to be very careful about the deployment of yet another biomarker, be it stroma or budding. Budding, I think, will come into routine practice, but again, there's all the caveats of what I've just said, is what do we stop doing in order to use budding? And so, again, I think we lack the studies for me really to advise clinicians as to which ones we should be using at the moment. Rob.
So, is budding, what's the link between budding and CMS4, EMT?
So CMS4 links to stroma and TGF-beta pathway. And so the hope is that if we get some new drugs against the TGF-beta pathway, and I think things like Quirke and stuff like that are supposed to be directed in that direction, then you might specifically be able to use it within that subtype. Budding and stroma are independent, so, and they're different because budding occurs at the edge of the tumour, fibrosis stroma occurs throughout the tumour, and so you can understand the physiology of the two, and the tumorigenesis are very different. But its role in CMS4 hasn't been specifically looked at. The reason we can associate it with stroma with CMS4 is because we can see all the TGF-beta genes up, but we don't know the genes that are related to budding. People say it's epithelial, mesenchymal transition, but these cells are cancer cells, they're epithelial cells, so I don't really get the thing about mesenchyme here. So we need a lot more work. All I think I can definitely say is that if you see a lot of tumour buds breaking off those tumours, they are definitely more aggressive. In the same way as you see more stroma, they're definitely more aggressive. But it depends upon the stage, it depends upon how well the surgeon treats them. We know stroma is not a predictor of sensitivity to therapy, because in Quasar we did not demonstrate any relationship between the stroma and sensitivity to 5-FU.
Another question? Yes. It's the last question.
Thank you very much. I have a question concerning the tumor budding and counting it. According to the consensus, we use immunostaining to identify the hotspot, and then we do the counting based on the age of the stains. But according to our experience, in several tumors, the tumor budding would have been greater if we did the counting using the immunostains. What should we do? Why don't we use immunostaining for the moment?
So you're quite correct. I always have a basic philosophy that we need to do pathology around the world, and also getting new resource to do something is difficult. If it doesn't take new resource, it's much more likely to come in. We have a problem with DMMR testing in the UK. It doesn't cost very much, but we can't get the money to do it, and that's because we need immunostains. So if we can do it without immunostains, I always prefer it because there's no cost to that apart from our time. It is highly likely that if you're using cytokeratins, that you'll definitely get more buds, and it will probably be more effective. It may be even more effective if we have automated algorithms that will pick it up. They work on the cytokeratins better than they work on the ordinary H&Es. But I think we ought to try firstly to do it on H&Es and to demonstrate how much extra superiority that we get with cytokeratin, and then whether that extra superiority is worth the €30 test, the 30 euros it would be to do that added in the cytochemistry. So I think you're quite correct. It makes it easier, but it's more costly, and it depends what drives your health system, and we're all being driven down at the moment, so trying to avoid the use of any extra immunos unless you have to is something we always try and adopt.
Okay.
Thank you.
Can I ask another question, please?
Talk to me at coffee.
Sorry, I'm very sorry.
Thank you.